Good evening, my dear students. Welcome to another recall class. I hope all of you are doing well. Let's just wait a couple of more minutes before everyone can join, and then we will start our class today. We'll be going through May sample questions today, but I remember that we haven't solved the last 4 questions of my previous class. So we'll discuss those first, and then we'll start the May sample question presentation, okay? Good evening, Dr. Sneha and Dr. Purna. How are you? There are a couple of people I have noticed who are in the class with names like Zoom Premium and Samsung SMT7. Can you please let me know your real names or join the class with real names? Because as per the course policy, if we don't know who you are, I might be removing you from the class. So please let us know about your name and join with the name that you have been registered in the course with. Otherwise, I'll be removing you from the class. Good evening, Dr. Khan. How are you? Okay, we have plenty of people, so we'll be starting our class because we have to go through a lot of things today. I'll be going in a bit. I'll be having a bit of speed, so let me know if it's too fast for you guys, and we'll just try to go through as many questions in the presentation as possible and try to complete it in due time. Sorry if I'm speaking a bit slowly. But yeah, let me know if you have troubles with my volume as well. Are you guys able to see the screen? Hello, Dr. Neri, how are you? If you are able to see the screen, just write Y in the chat box. Thank you. Alrighty, first question from the previous April recall session is, a woman with osteoporosis, she experiences a motor vehicle accident. Initially, she reports no neck pain. So at the time of the accident, she didn't report any neck pain. But the following day, she develops neck pain. And there is bilateral neck tenderness 3 centimeters away from the midline. So it's more lateral tenderness. And she's having pain with the neck extension. What is the reason for further investigation? Presence of osteoporosis, painful neck extension, painful lateral movements, bilateral neck tenderness, or lack of improvement with conservative management. So this is a lady who had a motor vehicle accident, has osteoporosis. She did not have the pain on the day of the accident in the neck, but now she's developing pain, which is more laterally and is more with the neck extension. So what in the following requires investigation? So we are having painful lateral movements. Okay, so is the patient is having tenderness at lateral side, but she's having pain with neck extension. So what requires, which one of the following out of these two is the reason for your investigation? So we know that presence of osteoporosis is a risk factor. It should be the reason for further investigation, but not in this case. This case is like patient is having neck tenderness, right? We haven't even done any conservative measurements. So lack of improvement with conservative management on initial presentation with neck pain requires further investigation. Painful lateral movements. She's not complaining of any painful lateral movements. She's having bilateral neck tenderness and pain with neck extension. So the reason we do imaging is the neck extension. Painful lateral movements is a criterion in the Nexus C-spine for imaging, but she is not having painful lateral movement. She's having neck tenderness and not complaining of any pain on the lateral side when she moves, but she's complaining of painful neck extension. So flexion extension and lateral movements, if painful, after a motor vehicle accident, requires radiography. So your correct answer is B. Is it clear, guys? They have given you the answer within the question. She's having bilateral neck tenderness away from the midline. If it was midline tenderness, definitely the answer would be for radiographic investigation. More than painful neck extension would be midline tenderness, right? But painful neck extension, they have already mentioned in the question that she has been having that, but not painful lateral movements. So pick a answer regarding what has been given. Is it clear, guys? We have already gone through the Canadian C-spine and Nexus C-spine radiography indications or indications for further imaging. So go through the same. If pain towards midline, then this is, if pain on midline, not towards. Midline tenderness, C-spine. This is one of the first criterias in, I think, Nexus C-spine to go for further imaging. Midline tenderness means that the patient is having pain on the cervical spines, the spinous part of the spinal cord, the spinal vertebrae, right? So that means that there is either injury within the vertebral structure itself, or there is injury, pressure injury towards the spinal cord. That's why midline tenderness is indicated for further imaging, especially CT scan of the neck. And if CT scan rules out all of the fractures, patient is still complaining of midline tenderness, we always do an MRI to rule out any spinal nerve injuries or spinal cord injuries. All right. I hope it's clear, guys. Next question. This is like the most repetitive question I have ever seen in my life. 24-year-old female. She has rheumatoid arthritis. She is currently on methotrexate and hydroxychloroquine and wants to get pregnant. What will you do? Stop methotrexate and continue hydroxychloroquine? Stop metho and start leflunomide? Stop both drugs? Only stop methotrexate? Doesn't say anything about hydroxychloroquine, and they have asked you about both drugs. Stop methotrexate and add adalimumab. So we all know the correct answer is option A, because methotrexate causes folic acid deficiency that leads to spinal cord problems in the babies. Hydroxychloroquine is completely safe to give in pregnancy in patients of rheumatoid arthritis. So if she is stable on hydroxychloroquine, we would stop methotrexate and continue the hydroxychloroquine. Similarly, methotrexate, if a male is on methotrexate and planning to start a family, he should be counseled about it, because methotrexate causes two things. It causes azoospermia and it causes chromosomal abnormalities in the sperm as well. So we stop the methotrexate at least 3 to 6 months before the person is to start planning for the pregnancy family. So link I have given over here, this is the randomized controlled trial they have done, where they found that those with the methotrexate had spinal cord defect because it causes the folic acid deficiency. So patients are always recommended to stop this medication and continue hydroxychloroquine, safer medications in the pregnancy. Alrighty, next question. Patient was admitted following road traffic accident, had rib fracture. You prescribed subcutaneous 10 milligram of morphine. Shortly, patient again complains that the pain is not settled. When checking upon the patient, you notice that nurse hasn't given morphine, as she thought that the dose was too high for him, and she just gave paracetamol to the patient. What will be your next action? Complete an incident form. Talk to the nurse and explain the effects on patient because of her action. Inform hospital director. Inform AFRA or confront her. So we always talk about why it wasn't done and try to listen to our colleagues' opinion. And then we complete an incident form. So we will do B first and then do A. Always talk to them about what the reason was they haven't given such and such medication. If their reason is valid, you still complete the incident form. If the reason is not valid, you complete the incident form in either ways, whether you like the reason or the reason is valid or not, okay? Alrighty, next question. 52-year-old male came to you following attempted to end his life, so suicide. He and his wife successfully running an interior design company. On further inquiry, he is telling recently he's not interested in work, not going to golf with his friends on weekends, and worried that he got delayed with new projects completion and pending work. So he's having stress at the work, which is affecting his social and family life. He's crying now. He has lost house and nowhere to go after discharge. What condition led to his presentation? Ruminations of guilty, delusions of poverty, paranoid delusion. So this patient has stress that work is not going good and where he will lose his house and where would he go after discharge. So he's having delusion of poverty. Paranoid delusion will affect his speech, behavior, hallucination, and delusion. So hallucinations will be there in paranoia. And suspicion, high level of suspicion will be there. Ruminations of guilty about what? They haven't clarified that. So ruminations of guilty is less likely to be the answer here. All right, so the last 4 questions were, I think most of them were repeated. So that's it with the last class. Let's start our May class. Are you guys able to see the screen? All righty. Where's my pointer? Okay. Grandmother brings the grandkid to the emergency or to the GP, whatever is the scenario. 6 months old baby, having diarrhea, abdominal pain, vomit, abdominal rigidity, and tenderness. Patient was having runny nose for 1 day. Parents of the kids were COVID positive 2 weeks back. What will you do next for the kid? COVID rapid antigen, COVID rapid PCR, ultrasound of the abdomen, X-ray, or ANO antibodies. So 6 months old baby, diarrhea, abdominal pain, vomit, abdominal rigidity and tenderness, upper respiratory tract infection symptoms for 1 day. Parents were COVID positive 2 weeks back. So what is coming in your mind as a diagnosis? Diarrhea is there, upper respiratory tract infection history there, has vomiting, abdominal pain with some rigidity and tenderness. What is very common in 6-month-old child with the presentation of such? Where your answer is absolutely correct. We will do the ultrasonography of the abdomen. Very good, doctor. What's her name? What's your name? Dr. Salma. Excellent. This is post-viral intussusception. So when I would agree to go for abdominal X-ray if there was no diarrhea, abdominal pain, vomit, abdominal rigidity, and tenderness, then I would suspect what? If there was no diarrhea, what would your answer would be? What would your diagnosis would be? It would be a bowel obstruction, right? So bowel obstruction, I would not go for ultrasonography of the abdomen. I will do an X-ray, right? But for intussusception, you have diarrhea, you have abdominal pain, vomit, abdominal rigidity, and tenderness. These are all the symptoms of intussusception. The age group fits. Also, it usually starts with the upper respiratory tract infections, right? It could be appendicitis as well. For appendicitis, again, ultrasound of the abdomen is the diagnostic tool we use in kids, especially. So the modality to use here is ultrasound of the abdomen rather than X-ray. Parents of the kid were COVID positive 2 weeks back. So 14 days is enough for them to get out of COVID. I would not do COVID test, but I will do like a respiratory panel, like a flu, influenza, RSV, adeno. I will do all of those just to make sure that the patient is not having any upper respiratory tract infection leading to lower respiratory tract infection. But that will be the secondary screening. Primary concern will be to find out the cause, which will be done by diagnostic imaging, which is the ultrasonography in here. Clear, guys? Alrighty, ANA is of no use here. What will ANA in a 6-month-old tell us? It will give us zero information. Let's just... Right. Are you guys able to see the screen? Still, let me have a look. Okay, I need to share. Alrighty. Are you guys able to see the clinical practice guideline on your screen? Royal Children's Hospital 1. Okay. So let's talk about intussusception. So it requires high index of suspicion. So it should be considered in infants and children with intermittent distress, vomiting, or isolated unexplained lethargy. Delayed presentation. If the child did have like a week-old history, then intussusception will present mostly as a small bowel obstruction or perforation / peritonitis and shock. Ultrasound is the initial study of choice. Intussusception, we know it's a telescoping of the proximal bowel into the distal bowel, leads to cutoff of the blood supply, which causes bowel obstruction features, can cause venous congestion in the surrounding area, can also lead to ischemia that can cause bowel perforation and peritonitis and shock. It's a sequelae that goes into intermittent abdominal pain, sometimes abdominal mass. Red currant jelly stools will be there in children whose gut is undergoing ischemia. So pain, a well-appearing child in between the pain, pallor, lethargy, vomiting, very prominent feature. Bile stain vomiting is a late feature and indicates bowel obstruction, rectal bleeding, or it is quite common and can lead to misdiagnosis of gastroenteritis. So vomiting and diarrhea is there. Rectal bleeding or red currant jelly stool is a late presentation as well, and it indicates that the bowel has undergone infarction or ischemia. Abdominal mass can be felt when the child is having painful episode. Distension can be there. Tenderness and guarding, they can suggest perforation or peritonitis, but sometimes it can be misleading as well. So you need to do an ultrasonography to rule out if there's perforation, or EFA scan to rule out if there's any free fluid in the abdomen. So inspection of the nappy and perianal region should be done. We don't usually do a rectal examination on kids, and kids can present with hypovolemic shock secondary to the perforation. So you give analgesia, resuscitate the patient by giving the IV access. You make sure they don't have anything by mouth. You notify the surgical registrar about it, and you organize an ultrasonography for this. So resuscitation is required if the patient is having signs of shock or hypovolemia. And if you have like bowel obstruction signs, like only abdominal pain, vomiting, then you make sure that you do an X-ray, abdominal X-ray. No signs, then you can consider ultrasonography and then start the patient on triple antibiotics And once the ultrasound is positive, you can do the contrast study, or the surgeons can just go in laparoscopically or start do gas enema, which helps to untelescope the obstructed bowel. This is a very important flow chart for your exam, guys. This solves like a heaps of question from here. So intussusception question can either come like a peritonitis / perforation / shock question, and they will ask you about what to resuscitate the patient with. They can give you signs of bowel obstruction by starting the question like patient had intussusception coming in late, now presenting with bowel obstruction / perforation. What would your next step would be? So that will be abdominal X-ray instead of ultrasonography. If just symptoms of early intussusception, ultrasonography, and then fluids, antibiotics, and contrast enema or gas enema by the surgical registrars or surgical consultant to untelescope the telescopic part of the intussusception. It has very high sensitivity and specificity, and abdominal X-ray when there's bowel obstruction. Contrast or gas enema is diagnostic and therapeutic. So once you enter that and put gas in it, it can untelescope the bowel as well. Other than that, we always do basic blood tests like venous blood gas, full blood count, liver function test, renal function test, urea electrolytes, and creatinine, just to make sure that the child is not having a deficiency in any of the other organs. Okay. Is it clear, guys? Any question? Okay. I have also given you a link for acute abdominal pain. So go through the RCH approach towards the acute abdominal pain in the children as well. All right, next question. 62-year-old male, history of hypertension and hyperlipidemia, presents to emergency department with crushing chest pain radiating to his left arm and jaw. It's a repetitive question, guys. On examination, he appears diaphoretic and his tachypneic. Blood pressure is 180 by 100 millimeter of mercury. Heart rate is 110 and oxygen saturation is 92 on room air. ECG shows ST segment elevation between in leads 2, 3, and AVF. Options of management are which of the following? Give nitroglycerin, give aspirin, give morphine, or give metoprolol. Very good. So we know that whenever a patient is having myocardial infarction symptoms, especially in the inferior leads, we will start the patient on aspirin. And what else, guys? We load the patient on aspirin and dual antiplatelet therapy, clopidogrel or ticagrelor. So we load the patient on these two, start the patient on the low molecular weight heparin drip to make sure that the clot is heparinized. And then we decide if the patient is in tertiary care center, we can decide to go for angiography / angioplasty, or we can decide to do thrombolysis therapy. This patient is having inferior myocardial infarction, inferior leads, ST segment elevation is there. Never give nitroglycerin in patients with the inferior leads myocardial infarction because it can cause bradycardia and hypotension in them. Low molecular weight heparin, we always start the patients before thrombolizing. It's a thrombolysis on anticoagulation therapy as well, along with aspirin and ticagrelor, till we decide whether the patient should have PCI or continue with just thrombolysis. It's a heparin infusion we start them on. Alrighty, very good. Now, if there was a option E that says start the patient on oxygen, then we will follow airway breathing circulation criteria and start the patient on oxygen before giving aspirin first, okay? The saturation is 92% on room air. This patient should be resuscitated according to the trauma protocol as well. All right, so I'm not gonna go into detail, but I'll just show you guys what sort of link I have given you. This is the Australian Heart Association. Uh, we usually load the patient. So A, B, C, D. Airway, breathing, circulation, disability, exposure. Airway, breathing, circulation is maintained. Then you disability, exposure, check the blood sugar level, blah blah blah. That after that, it's usually like a once or hardly a minute evaluation in which we do A, B, C, D. So patient should be given aspirin, clopidogrel, oxygen should be started before that, and then make sure that you give patient morphine. Yes, aspirin is the first one to give. Then make sure that you have given morphine or fentanyl to the patient as a PRN, 25 mics every 2 hourly. If the patient is not having inferior lead myocardial infarction, you can also give them GTN. And also, we should start the patient on metoprolol, which is the beta blocker and ACE inhibitor to control the blood pressure so that they don't have like a big ventricular dysfunction or high blood pressure doesn't cause them to throw a clot into the brain as well. So these are all done like step by step, but oxygen, if they have given you oxygen option because the saturation was 92% before giving aspirin, put the patient on supplemental oxygen, give aspirin and dual antiplatelet agent like ticagrelor and clopidogrel, morphine, GTN. So these are the things. We always start the patient on the metoprolol and beta blocker and ACE inhibitor as well if there is no contraindication. So go through this, guys. 94 to 95% at room air. Go through this, guys. These are the guidelines. You can download this from here. So go through that. It's a very good guideline for practical use as well. Do we need heparin infusion for STEMI too? If you're waiting for cath lab to get ready and you think it's taking time, you can always start the patient because heparin is very short acting. So once you have established the patient is going to the cath lab, you can stop the heparin and take the patient to the cath lab for PCI. If the patient is having non-STEMI, then heparin infusion definitely. Alrighty. Okay, we have done this. Next question. You need to be very careful about whether they have said like tertiary center or secondary centers. Secondary centers don't have cardiology cath lab, so your answer will change based on where the patient is going. Sometimes they do that a lot in your examination. They will give you like, oh, patient is coming to the tertiary center or it's in a rural area hospital. So what will you do? So your answer will clearly depend on whether they have the facility of cath lab or not. And cath labs are in tertiary centers most of the time. 55-year-old male presents with severe abdominal pain. This is a very easy question, to be honest. Nausea and vomiting. On examination, he has suprapubic tenderness and a palpable urinary bladder. Urinary catheter is inserted and 800 ml of clear yellow urine is drained. Which of the following is the potential cause for it? Renal colic, acute urinary retention, acute cystitis, and acute pyelonephritis. So we will go through each and every one because we know the answer is acute urinary retention. In renal colic, patient will have severe right or left-sided flank pain associated with nausea and vomiting, and sometimes a bladder stone will also cause suprapubic tenderness, but patient can have urinary retention secondary to it. But if you catheterize this patient, you will see macroscopic hematuria. So renal colic causes hematuria, guys. Acute cystitis, patient will have stinging and burning sensation when he wheezes. Urine will be yellow, dark colored, and very smelly. It cannot cause retention unless patient has like stricture development secondary to the infection, which takes like a long time to develop. Acute pyelonephritis, patient will present with right or left side flank pain, fever, nausea, vomiting, and sometimes they can have acute cystitis associated with the pyelonephritis as well. But pyelonephritis is kidney infection, so more systemic features will be there, and renal angioteninus is positive in this case. Alrighty. So for acute urinary retention, your treatment is you immediately do IDC drainage, and then you monitor the patient by doing the bedside bladder scans to find out whether the patient is having post-void retention or not. Renal colic, the first investigation we do is the CT scan. If the patient is having less than 5 to 7 millimeter stones, then we give pain relief to the patient. Yes, we do the urine MCS and renal colic as well, but the first line investigation is the CT scan. So we, in renal colic patients, if the stone is 5 to 7, then we usually give pain relief, mostly NSAIDs that causes or prevents the spasm of the ureter. And then just ask the patient to pee in a bottle for the next 3 days so that they are aware when the stone passes. Acute cystitis, we give antibiotics. Acute pyelonephritis, we give antibiotics to the patient. And investigation for both of them is urine NCS. This is a big PDF for urinary retention. It's a big. What I want to discuss in this, there is a talked about a lot of things. What I want to discuss here. Okay, urinary obstruction. So different causes. Upper urinary tract obstruction has different causes like aneurysm, calculi like stones. Oh, screen not visible. Sorry about that. Thank you, Dr. Iris. So upper urinary tract obstruction, flank pain, back pain, groin pain, nausea, vomiting, aortic abdominal aneurysm, very rare. Stones, very common, carcinomas, congenital conditions like horse-shaped kidneys, trauma, very common, papillary necrosis, common, pregnant uterus, very common, retroperitoneal fibrosis, not so common, tuberculosis, not so common. Lower urinary tract obstruction, sometimes anticholinergic medication, recreational drugs. Very common in males is the BPH. Not very common in elderly people, very common, cancer. Detrusor muscle overactivity, very common. Fecal impaction, very common in the elderly. Foreign body is not very common. Medications, anticholinergic, antihistamines, antispasmodics, very common. Trauma, spinal and cerebral lesions common. Stones, stenosis, and strictures are common. Alrighty, urine retention, we have talked about this. This I want you to read through. So if lower urinary retention, patient has lower abdominal pain, discomfort, incontinence, inability to void, you do an assessment in which you review the risk factors, physical examination, urine analysis, and bladder scan. Then we see whether patient has actual urinary retention with distress and agitation. Then we immediately do a IDC and then modify and monitor most of the time the risk factors that can contribute to it. If the patient is having no pain, distress, and agitation, then we usually ask the nursing staff to monitor. And if it is more than 1,000 mils, or if the patient is not voiding, then we usually ask them to catheterize the patient and monitor the urine output, whether the patient might have clinically AKI or not, or what's the cause of the urinary obstruction in them or retention in them. This is very important. So when you have catheterized a patient in a urinary retention, what we do is we check the bladder, we monitor the urine output, and then we do trial of void. Trial of void is that after removal of the catheter, we do minimum measurements of the patient's 3 voids to ensure that there is no residual urine volume of more than 70 to 30 mils inside the bladder. So it's a whole clinic and it's run by the nursing staff who does the trial of voids. That's about it. Okay. Any question, guys? Okay. Next one. A 45-year-old female has a history of COPD. She presents to emergency department with sudden onset of dyspnea and pleuritic chest pain. She is afebrile but tachypnic. ABGs reveal that she is having respiratory alkalosis. What is the diagnosis and subsequent management? Pulmonary embolism requiring heparin, pneumothorax requiring, one question not visible. It's showing that the screen is visible. Is it visible, this question on the screen, guys? Because it's showing here that it's visible. Oh yeah, it is visible, guys. All right. Pulmonary embolism requiring heparin, pneumothorax requiring chest tube, acute exacerbation of COPD that requires bronchodilators and corticosteroids, and acute respiratory distress syndrome. Okay, we are having answers B and C. So can anyone tell me in COPD what kind of arterial blood gas we have? Is it respiratory alkalosis or respiratory acidosis? We have acidosis, very good. So C is not the answer. Acute respiratory distress syndrome includes ABC. So very broad term. She is presenting with sudden onset of dyspnea, has a background of lung disorder, pleuritic chest pain, afebrile, tachypnic. Is there any risk factor for pulmonary embolism? Can anyone give me any risk factor they have given in the question for pulmonary embolism? So when there is no risk factor, so what's the answer? It's pneumothorax. Is it spontaneous primary pneumothorax or secondary pneumothorax? Very good. So patient is having underlying lung disorder. Whenever there is an underlying lung disorder, it is secondary pneumothorax. It's never primary pneumothorax. Let's have a read of this, guys, quickly. Okay, so this is from the New South Wales Emergency Institute guidelines. Primary pneumothorax is a pneumothorax occurring in a patient when there is no underlying cause for it, and there is no underlying lung disorder, trauma, or surgery, whereas secondary pneumothorax is because of the underlying lung disorder. Symptoms which the patient will present will be chest pain, stabbing, pleuritic in nature, one-sided, sudden onset of shortness of breath, anxiety, cough, and vague chest symptoms. What are the signs? There will be respiratory distress on the affected side on examination. Chest movements will be decreased, expansion will be decreased, and breath sounds will be absent. On percussion, the resonant, hyperresonant. If she came with hemoptysis, I would be very concerned, and I would not opt for pneumothorax. I would go with pulmonary embolism. Pneumothorax never cause hemoptysis, guys. Even the exacerbation of the COPD doesn't cause hemoptysis. Hemoptysis, acute respiratory distress syndrome. Let me just open up for you. It's a very broad term. When fluid builds up in the tiny elastic air sacs. Let me just open this up. No, not this one. Where's that? Images. Why alkalosis? Because of the no expansion of the lung. Okay. Acute respiratory distress syndrome occurs because of pneumonia, aspiration, trauma, sepsis, transfusion reaction. Because it leads to accumulation of the fluids in the lungs. So differentials could be congestive heart failure and bilateral PNA. So you do a VQ scan. What happens is that injury is there, alveolar macrophages activation is there that gets filled up with fluids. Onset is less than 7 days. You do chest x-ray that shows bilateral opacification. What else? So treat underlying cause, titrate peak pressure, conservative volume resuscitation, inhaled vasodilator, and recruitment management. So it's basically like fluid retention inside the lungs. This one. Acute respiratory distress syndrome. So same as the congestive heart failure, but the etiology is different. Okay, where was I? Okay. So diagnosis, you either do ultrasound or you do chest x-ray. And then when you find that it's more than 15% / symptomatic, we do aspiration, needle aspiration of the pneumothorax. Alrighty. Is it clear about why alkalosis is happening, Dr. Chandima? So there is problems with the lung expansion, right? Why alkalosis happens. All right. Secondary to respiratory alkalosis. Where is it? Not this one. Collapsed lung causes. So it's generally caused by hyperventilation, but in pneumothorax, which is a collapsed lung, the collapsed lung leads more pressure on one lung, leading to tachypnea, leading to hyperventilation, leading to respiratory alkalosis. Respiratory alkalosis also happens in pulmonary embolism as well. Don't forget about that. Asthma and COPD will not give alkalosis. Rather, they will, if asthma is like chronically present, then they will give you respiratory acidosis instead of alkalosis. Secondary pneumothorax. I don't remember actually. I remember primary pneumothorax. I don't remember the secondary pneumothorax. Good question. We will see what's the management of it. Management options. Spontaneous pneumothorax. What do we do? Where is it? It's been such a long time since I have read spontaneous pneumothorax treatment option. Okay, primary. If Observation is the treatment of choice for the small primary spontaneous pneumothorax without significant breathlessness. If patient is having significant breathlessness or particular size of the pneumothorax, then you need to do needle cannula aspiration, 14 to 16 gauge one. In secondary pneumothorax, all of them require admission. A large symptomatic requires small bore chest drain as a first line treatment. If it is a very small one, then try to aspirate first. If this reduces the size, then it's fine. If not, then you need to put a chest drain on it. So first line in treatment option for the secondary pneumothorax is chest tube placement. First line option for primary spontaneous pneumothorax is needle aspiration. Okay. Next question, guys. Happy if I move forward? Chronic lung disease is not a risk factor for B, unless patient is like smoker, had unprovoked DVT in the past, had been on steroids, has history of cancer, surgery, immobilization. They will give you something. It's not just having a chronic lung disease is not a risk factor. 68-year-old female presents to emergency department with sudden onset of dyspnea, orthopnea, paroxysmal nocturnal dyspnea. She has a history of high blood pressure and atrial fibrillation. On examination, crackles are heard bilaterally on lung auscultation and JVP is raised. Options for diagnosis and management are which of the following? Is it acute myocardial infarction requiring thrombolytics? Is it heart failure exacerbation requiring diuretics and oxygen? Is it aortic dissection requiring intravenous beta blocker, or is it pulmonary embolism requiring thrombolytic? So very typical scenario is given for you guys, which is heart failure. It is a decompensated heart failure by the looks of the sign and symptoms given. So we will start the patient on oxygen therapy if required, but first line treatment would be diuretics and then heart failure therapy. Can anyone tell me the 4 pillars of the heart failure therapy? It can be sudden onset. Acute decompensated heart failure is sudden onset. Can anyone tell me what are the 4 pillars of very good ACE inhibitors? Number 2, beta blocker when the blood pressure is stable, very good. Beta blocker, statins is not, spironolactone, MRA, very good, and SGLT2 inhibitor. So always remember, when a patient presents with heart failure, if he has no contraindication, we start the patient on ACE inhibitor, MRA, mineralocorticoid antagonist, which is spironolactone, SGLT2 inhibitor, and beta blocker. These are the 4 pillars of heart failure therapy. So what they do is help strengthen the heart and remodel the heart as well. So they reverse the effect of the heart failures. Empagliflozin and dapagliflozin. It was originally found to be the heart diabetic medication, but they have the heart role model. They have a role in remodeling of the heart and in remodeling of the or repair of the conduction system as well. Especially spironolactone also is. It will help in atrial fibrillation sometimes, but it helps in the remodeling of the heart. Alrighty, access the guideline, please. 4 pillars are beta blockers, ACE inhibitor, SGLT2 inhibitor, and MRA. Smoking cessation is recommended. Smoking cessation is recommended. Avoid excess alcohol is recommended. Weight reduction, regular physical exercise is recommended. We have a heart failure. cardiac rehabilitation clinic as well. Blood pressure lowering and lipid lowering agents are recommended, especially if the patient has background of myocardial infarction. ACE inhibitors should be considered in patient with cardiovascular disease to reduce the events of cardiovascular events and risk of developing future heart failure. SGLT2 inhibitors are recommended in patients with type 2 diabetes mellitus associated with cardiovascular disease. Even if the patient doesn't have type 2 diabetes, and if there is no contraindication to SGLT2 inhibitor, we also start them. And they decrease the risk of hospitalization for heart failure and decrease the risk of cardiovascular events in future. ACE inhibitors are especially recommended in patients who have like left-sided ventricular dysfunction. Beta blockers, when the left ventricular systolic dysfunction is stabilized a bit on the ACE inhibitor, then we start the patient on beta blocker, especially bisoprolol, nebivolol. They are very effective. Acute heart failure, oxygen therapy is recommended if the patient is having low oxygen saturation. You can also start the patient on BiPAP as well. Loop diuretics, if the patient is in fluid overload, loop diuretics is recommended. To help, vasodilators can be considered if the patient blood pressure is more than 90 millimeter mercury. Inotropic therapy can be considered if it is less than 90. Hypoperfusion is there. If the patient is not having any hypoperfusion, we don't recommend to use the inotropic. Vasodilators like ACE inhibitors should be started. ACE inhibitors, beta blockers, which type of beta blockers. So we need to be very careful. Echocardiography in a heart failure is important because they need to tell us about the left ventricular ejection fraction. So if the patient is having left ventricular ejection fraction less than 40, or very, very low, then we usually don't start the beta blocker. We make sure we start on ACE inhibitor, SGLT2, spironolactone, make sure they are getting better. Once the left ventricular ejection fraction is stabilized, then we can start the patient on beta blocker. Bisoprolol, carvedilol, and metoprolol are the best ones. Mild, like 41 to 49, you can start as well. Okay. Yes. Mineralocorticoids can be started. Diuretics until the patient has like the signs of congestion are reduced or completely inhibited. Ivabradine, it's considered in patients who are having heart failure with reduced ejection fraction. It's like a second agent you can give to the patients who are not responding to the diuretics. Ivabradine is very carefully used because it can cause blocks in the patient, especially if concurrently used with the beta blocker, or if the patient is already having low heart rate. So very, very careful in using that. Digoxin can be used in patients with HFrEF, despite receiving maximum doses of the above mentioned therapy. Okay. Exercise is also very important. This helps a lot in building the exercise and tolerance of the patient. Alrighty. Implantable cardiovertebral defibrillators are indicated in patients who are having biventricular heart failure associated with the conduction defect. Okay. So you can consider in patients who are having primary prevention indication in patients with HFrEF associated with ischemic heart disease, associated with the conduction defect. So yes, ivabradine in patients with ejection fraction less than 35, usually we start. It can be started on patients who are having like 41 up till 40 as well. But most of the time, a reduced ejection fraction is the indication for starting it. And it's not one of the 4 pillars. It's a secondary line drug that we use. Alrighty. Next question. 35-year-old smoker, present to emergency department with sudden onset of pleuritic chest pain and hemoptysis. He is tachycardic and hypertensive. Blood gas reveals respiratory alkalosis. What is the diagnosis? Pneumonia, antibiotics and oxygen, spontaneous pneumothorax, chest tube placement, pulmonary embolism, heparin on oxygen, acute exacerbation of asthma requiring bronchodilators and corticosteroids. Now we know they have given us a risk factor, which is smoker. So now we know the answer is pulmonary embolism. So pulmonary embolism requiring thrombolytic therapy. Very good. Okay, let's go through this one. Oops, sorry. Oh, I think this one, sorry. Let's see. Pulmonary embolism. Sign and symptoms. So majority of the time, dyspnea, pleuritic chest pain, cough, syncope, hemoptysis. Clinical examination reveals that sorry about that. They have tachycardia, cyanosis, tachypnea, sometimes low-grade fever, and if it's very huge, then right heart failure, including distended jugular veins, tricuspid regurgitation, and the accentuated or exaggerated pulmonary component of the second heart sound. So we do well scoring. And if you have uncertainty about the pulmonary embolism, we do D-dimer to exclude it. Medical imaging, we do chest x-rays followed by CT, PA, and if it's contraindicated, we do VQ scan. Suspected PE, clinical decision rule, P unlikely. If you think that there is low probability, you do D-dimer. Normal, no requirement, increased CTPA. P likely or clinical probability is high, then you do a CTPA or a VQ scan. Duration of the anticoagulation depends upon your risk factors. So usually 3 to 6 months. Where are the risk factors that I wanted to discuss? It's not here. Okay. There used to be a mnemonic for the pulmonary embolism risk factors. So surgery, trauma, which is prolonged immobilization, obesity, hypercoagulable state like malignancy, peripartum, very, very important in the postpartum period, nephrotic syndrome, thrombophilias, smoking, previous DVT, indwelling venous catheters, medications like HRT, steroids, chemotherapy, increasing age. Just gonna put it up here so you guys will remember. All right. What are the levels of well score for D-dimer and CTPA? Well score 4 and above requires CTPA. 4 less or low probability requires a D-dimer. There is a site called MedCalc. MedCalc. Well, so whenever we are in the emergency, we just open this up. So this is the Wells criteria. Clinical signs of sign and symptoms of DVT. If present, +3. P is number one diagnosis or very likely, yes, +3. Heart rate, tachycardia, immobilization, surgery, previous PE or DVT, hemoptysis, malignancy, treatment within 6 months. So if like do this, so they will give you a result. So 3, 3, 4, 5, 5.5 is a well criteria for it. Ma'am, can CTPA be done in reproductive age group now or still VQ scan prefer? It depends upon the availability, Dr. Mehra. If we don't have a VQ scan facility available, theoretically, VQ scan should be preferred in the reproductive age group. If we don't have the facility, CTPA is done. And CTPAs, practically, CTPAs are more regularly available than VQ scans. To be very honest, I have like never seen a patient having a VQ scan in my 2 years of practice. Never, because we don't have it available I work in a secondary hospital, so we don't have the facility available. We have CT scan, so very easily done. A scenario was given about pancytopenia, hyper-segmented neutrophils present. In order to further diagnose, what do you want to do next? Vitamin B level B12, I think, should be done. X-ray, bone marrow, or blood culture. So pancytopenia with hypersegmented neutrophils are present. What do you want to do next? Vitamin B level. Let's just remove B12. Vitamin B level, X-ray, bone marrow, or blood culture. So blood culture, we never do. Pancytopenia is there with there's two things they have given here. They have given you pancytopenia and they have given you blood film of hypersegmented neutrophils. So for further diagnosis, what do you want to do next? Do you want to do vitamin B12 level or do you want to do bone marrow? So if I go literally into the question, I would go with vitamin B level in the blood because they haven't given me what they want to do with bone marrow. Like bone marrow what? So I will take this question with a grain of salt, to be honest. Okay. Let's talk about like in what if scenarios, okay? So if pancytopenia has been given in the like hemoglobin is low, platelets is low, white cell count is low, but they have given you like blood film is suggestive of vitamin B12 picture, then the next one should be vitamin B12. If they have given like pancytopenia and blood film picture of pancytopenia, then yes, bone marrow aspiration and cytology will be done. So aplastic anemia with vitamin B12 deficiency blood film, less likely to be aplastic anemia because vitamin B12 deficiency, it can cause aplastic crisis as well. So if they are asking in literal sense about what do you want to do next, not best, then I would suggest you guys pick option A, that check the vitamin B12 level first. Hypersegmented neutrophils is not present in any other disease. If they want to do what is the definitive diagnosis, then go for bone marrow aspiration. Okay. All right. Let's have a look at the theory. Theoretical knowledge will help you guys because the questions in exams are not this incomplete. Let me assure you about that. So for hematology, I always recommend that you guys study from MedBullets. It's very easy to remember. They have given questions as well. So Let's have a look. 55-year-old man is brought to primary care physician by his wife for increased confusion. He forgets to turn off stove after cooking, frequently misplaces his key. He fell approximately 1 week ago while walking in the dark. His physical examination is notable for impaired short-term memory, decreased vibration and proprioception, and patellar hyperreflexia. On lab investigation, he has microcytic anemia, reticulocytopenia, and vitamin B12 low. So this is how the scenario for not the hematological side of vitamin B12 deficiency, but the deficiency that affects the central nervous system presents. So overview, it results into anemia, it results into dementia, and most concerning one other than the megaloblastic anemia or the dementia is the subacute combined degeneration of the spinal cord, which is reversible completely because it's just because of the deficiency of the vitamin B12 inside the body. All right. So etiologies can be decreased oral intake, decreased absorption because of the surgeries, illness of the GI medications like PPI, histamine receptor antagonist, metformin, or some autoimmune disease like pernicious anemia, in which the factors for vitamin B12 absorption is missing. So autoantibodies against the intrinsic factors that bind with the vitamin B12 and get them inside the body. Don't need to know about the pathophysiology. Symptoms of anemia, fatigue, dyspnea, GI symptoms like glossitis, neurological cognitive decline, subacute combined degeneration of the cord. So subacute combined degeneration of the cord, if we draw the spinal cord, pardon me for my, it affects the lateral spinal tracts and dorsal spinal tract. So remember the outside and the back side. Lateral spinal cord tracts, corticospinal tracts are involved in the motor part of the body. So weakness, spasticity, hyperreflexia will be there. So, and the dorsum are involved in the vibration and proprioception. So decreased vibration and proprioception sensation leading to gait difficulties. It also affects the spinocerebellar tracts, which will accentuate the gait difficulties, ataxia, and the proprioception sensation. But most of the time, the first two are the ones which are commonly affected. Serum investigation is that we do a full blood count. We have no, we don't have to pay for MedBullets. Just search in the Google search engine, it will be there. Okay, so microcytic megaloblastic anemia, decreased serum B12 level, reticulocytopenia, and peripherals shows hypersegmented nucleus with megalocytes. So look at the neutrophil, 1, 2, 3, 4, 5, 6, hypersegmented. It's very typical of that. You give injections. Okay, what are the complications? Irreversible nuclear damage. It can also cause pancytopenia, very commonly. It's a well-known cause of the megaloblastic anemia and pancytopenia, so it can affect all cell lines. Splenomegaly and leukoerythroblastosis, much less common, but it can affect the red blood cells, white blood cells, and the thrombocytes. Okay, pancytopenia can occur with it. Okay. It's not common in B12, but it definitely causes it. So don't get confused about it. Vitamin B12 deficiency can lead to aplastic anemia. Alrighty. Let's take a 10 minutes break, guys. I forgot the time is a bit up. Let's take 10 minutes break and then we'll come back and finish our class, okay? And you don't have to pay for MedBullet subscription. It's absolutely free. Oh, 10 minutes break. I'll see you guys at 9:49. All right, guys, welcome back. Let's start again. Are you guys able to see the screen? All right. A patient is coming to you with amenorrhea for 12 months. No sexual intercourse for 1.5 years. What investigation would you like to do first? FSH, LH, estrogen, progesterone, TSH, or urinary beta HCG? So they haven't given us any age. They haven't given us any. So if I amend this question, for example, like 24 years old female with amenorrhea. Now what's the answer? It's a 24-year-old female with amenorrhea for 12 months. No sexual intercourse for 1.5 years. What is your first investigation? What would you check first? Do we check for pregnancy first, or do we do the hormonal assessment FSH and LH? Check for beta HCG first, guys. This is the first investigation we do. FSH, LH, estrogen, progesterone, TSH, pelvic ultrasound. These are second line investigation. But the first thing that we do is check the pregnancy test. It's the protocol. It's the protocol. Whenever patient comes with secondary amenorrhea, doesn't matter the time frame, doesn't matter if it's in a relationship or not, always follow the protocol. So this is the protocol. Always do a beta HCG. Oh, this is not very clear. All right. Give history, physical examination, review medication, including contraceptions and illicit drugs, do pregnancy test first, then do serum LH, FSH, TSH, prolactin levels, pelvic ultrasonography, or other lab testing if indicated. If your FSH, LH levels are elevated, then you repeat it in 1 month and consider the, if it's again elevated, then you consider diagnosis of primary ovarian insufficiency. If you have normal or low FSH or LH, then you check whether the patient is having any eating disorder, stress in life, poor exercise, nutritional status, or excessive exercise. If patient is having normal or low FSH and LH associated with central nervous system, pregnancy test negative, then you FSH, LH, TSH, prolactin levels, pelvic ultrasonography. Basically, this algorithm you follow. Okay, so it can be primary ovarian insufficiency if FSH, LH levels are high with negative pregnancy test. It can be functional amenorrhea with association with the chronic illness or decreased nutritional intake or excessive exercise or eating disorder. It can be a cranial pathology like from the pituitary gland itself. So we do an MRI. If FSH-LH levels are low with evidence of hyperandrogenism, you check serum testosterone levels and you check 17-hydroxyprogesterone levels. So it can be either PCOS or it can be congenital hyperplasia. Dr. Aksara, we don't in primary amenorrhea. Good question. Let's check the primary amenorrhea first. Doesn't matter if they have given sexual history or not. Secondary amenorrhea, there is a protocol. Every patient undergoes these investigations, whether they are in a relationship or not, if they consent to it. There's a similar, okay, let me just increase this in size. image. Not very clear, but can you see this? No, I know it's a little blurred. Too small letters, I know. Sorry about that. Let me just see if this is much better. Let me open this up. Okay. How about now? Are you guys able to see this? Okay. History and physical examination completed for a patient with primary amenorrhea. So in primary amenorrhea, we go with secondary sexual characteristics present or not, right? So if no secondary sexual characteristics are present, then we go for FSH and LH levels. If they have given like secondary sexual characteristics are present, then perform ultrasonography of the uterus. So if there is no secondary sexual characteristics and FSH and LH levels are low, then it is hypogonadotrophic hypogonadism. And if it is secondary sexual characteristics are not present, but FSH level is low, but FSH and LH levels are high, then it is hypergonadotrophic hypogonadism, and we do karyotypic analysis on them. It can be either there is premature ovarian failure in 46XX, or it can be a Turner syndrome patient. Then if secondary sexual characteristics are present, we are not very worried about the hormones. We perform ultrasonography of the uterus as a first line. Then we see whether uterus is present or not. If the uterus is absent or if it seems abnormal, then we do karyotypic analysis for Mullerian agenesis and androgen insensitivity syndrome. But if uterus is present, then we do a transvaginal ultrasonography to see whether there is any outflow obstruction or not. It can be a transverse vaginal septum or imperforate hymen, or it can be a secondary amenorrhea. Okay, I'll add it to you. There you go. Alrighty. Cool, guys. All right. No worries. After appendectomy, what do you want to give to the patient post-operatively in terms of fluid? Normal saline or normal saline with dextrose or KCI, or no fluids are required? So why are we, your answer is absolutely correct. Why are we giving 0.9% normal saline, 5% dextrose, and 5% KCI to the patients of post-appendectomy? To prevent what? Your answer is absolutely correct. We want to prevent what? Very good. We want to prevent paralytic ileus, and to prevent paralytic ileus, we need to make sure that the patient has potassium and sugar in the fluids. Okay. There is a big article if you guys want to read about this. I'm not going to go into detail about this. Okay. I've given like 2 articles here. So perioperative fluid therapy for major surgery. This is an article, but this is a research article in which they have given like randomized controlled trial in patient which was given Hartmann solution and those who were just given normal saline. All right. Next question. 85 to 60-year-old. No, not 85. 60-year-old female is coming with tenderness of one breast. There is no mass. Family history of breast cancer in mother and sister. She's currently on spironolactone. What do you want to do next? Ultrasonography, fine needle aspiration, discharge spironolactone. I don't know what does discharge spironolactone means, but these are your options. So she's a 60-year-old female, has unilateral breast tenderness. You can't feel any mass, but she has a high risk breast cancer, family history with the breast cancer in mother and sister. She's currently on on spironolactone. So what do you want to do next? I agree with you, Dr. Nosheen and Dr. Priyanka. She should be having mammography because her breast will be very condensed, but they haven't given us any option for mammography, so we will do ultrasonography first. Alrighty. Over here, patient presents with breast mass or our patient with the high risk factors. We obtained history, performed clinical breast examination. So breast examination, the triple therapy approach is the breast examination, imaging, and then biopsy. So examination doesn't suggest any mass. You repeat the clinical examination in 2 to 3 months. If there is an indeterminate lesion or a patient of high risk, like our patient was, so if patient is younger than 30 years, we do ultrasonography. If he's more than 30 years, we do mammography with or without directed ultrasonography. If there is a suggestion of the suspicious mass, then we do diagnostic mammography and directed ultrasonography, and then we do ultrasound guided biopsy in this patient, which is more likely a core needle biopsy. Okay, guys. Alrighty. Next question. This is very easy as well. 10-week baby, born full term, normal delivery, had vaccination 2 weeks ago. Now is presenting with irritable cry, constantly loose bowel, with streaks of blood in the poo. Which of the following is the next best management option in this patient? Option 1, reassure the parents that it's related to vaccination. Number 2, do stool culture and sensitivity. Number 3, urine culture microscopy, or do a blood culture in the patient. Very good. So it's a very vague question, but you have certain things to guide you towards the investigation. So 10-week-old baby, full term, normal delivery, vaccination was done 2 weeks ago, but now he's having irritable cry, loose bowel with streaks of blood in it. The first thing we will do is the stool culture and sensitivity after the examination of the area, because sometimes babies can also have like fissures that can cause streaks of blood or constipation. But it's always better to do stool culture and sensitivity to make sure they don't have any rotavirus infection in them. Urine culture and microscopy should also be done in this patient because sometimes a UTI can also cause a diarrhea that can, if excessive, can cause streaks of blood to present in the baby. But first one should be stool culture and sensitivity. Patient is not febrile, so unnecessary to do blood cultures here. Okay, this is a fairly easy question. All right, next one. 22-year-old girl came back from Bali 3 weeks ago, now complaining of anorexia, nausea, right hypochondrium pain for 3 weeks, which is progressing. She doesn't have any fever. She took doxycycline for malaria prophylaxis. Her bilirubin is very high. All of the LFTs are abnormal except albumin. What's the best investigation you want to go for? CT abdomen, ultrasonography, MRI, or thick blood film? Okay, what are you thinking about in terms of your diagnosis? It seems more likely hepatitis A. Biliary obstruction. Look, in biliary obstruction, it's a travel history anorexia, nausea, right upper high quadrant pain for 3 weeks, which is progressing in nature. Bilirubin is high. All of the LFTs are deranged. So either it's doxycycline that is the culprit, or she is having hepatitis. Hepatitis can also cause ALP and GGT to be increased. Just give me a minute, guys. I'll be back in a second. All right, sorry about that. All right. Where was I? If viral study is given an option, then we should choose that. Look, ultrasound abdomen will help you to rule out any structural deformity with the hepatobiliary system. So if they have given next investigation, I would definitely recommend to do the hepatitis A, B, C serology. But they are asking about imaging, and they have given lots of imaging options here. Thick blood film, I wouldn't do, because this doesn't give like dengue fever kind of situation. So most likely hepatitis. So best one would be to do ultrasonography of the abdomen at this point. I've given you the article for hepatitis, same what we have discussed. Alrighty, next one. Man presents to the emergency, frequent diarrhea with every episode. Also have facial flushing with redness. Examinations are unremarkable. What do you want to check next? Aldosterone level or cortisol level? I think this question is wrong. Anyone agrees with me? What is your diagnosis based on just the course question? Yes, carcinoid syndrome. So what should be the investigations for carcinoid syndrome? Yes, it is carcinoid syndrome. What do we do for the evaluation of the carcinoid syndrome? Urinate. Yes, very good. What else? Usually we do 24-hour urine for 5-HIAA, which is usually the initial diagnostic test. Is there anything else we do for it, like imaging or something else? Very good. Chromogen A, we also check. Very good. What else? Pancreatic polypeptide, serotonin levels, histamine and substance P, and then we do a CT/PET scan and sometimes capsule endoscopy as well. Let me just open up. There is a flow chart that I'm very, very fond of for carcinoid syndrome. So this question is absolutely wrong, guys. This is carcinoid syndrome. Let me show you guys that. Carcinoid syndrome investigation. Oh, yes, this one. Look at this one, guys. If you're suspecting a carcinoid tumor or syndrome, and you have classical symptoms like diarrhea, flushing of the face, itching, then you check for chromogen A, serotonin, gastrin, histamine, substance P, and 5-HII, which is a diagnostic test. If you have some specific symptoms, you can do chromogen A and pancreatic polypeptide provocation test as well. If either of those are positive, then we do CT, PET scan, MRI to look for this tumor. If it's in stomach, then ultrasonography, endoscopy, biopsy. If it's in small bowel, capsule endoscopy, enteroscopy. If it's in colon, colonoscopy, biopsy. If it's in liver, ultrasonography, CT biopsy, and cardiac echocardiography, because it causes deposition in the heart as well. So this is carcinoid syndrome caused by carcinoid neuroendocrine tumor. All right. Next question. A patient presented with fever, vomiting, headache. CT scan of the head and neck shows a mass in the posterior fossa of the neck. Which of the following could be the potential diagnosis? Abscess, medulloblastoma, or neuroblastoma? This is very easy question, and they have given you like big words to distract you. Fever, mass, vomiting, headache. These are all features of, and they have like a mass in the posterior fossa of the neck. This is abscess. Okay, for abscess or anyone with the any adult which is presenting with a neck mass, if there are infectious symptoms like unilateral cervical adenopathy or fever, then we treat it with antibiotics, and if it resolves, then it's fine. If it doesn't resolve, then we are suspicious for it to be a malignancy. Then we do a CT scan associated with the fine needle aspiration and cytology and obtain the diagnosis and manage the diagnosis. Neuroblastoma and Wilms tumor, neuroblastoma with medulloblastoma as well. So nephro and neuroblastoma associated with opsoclonus myoclonus syndrome, cross the midline, fixed and immobile. It's usually in the abdomen. Wilms tumor is nephroblastoma. It's of the kidney associated with Wagner syndrome. Doesn't cross the midline, may be displaced, no constitutional symptoms are there. And then there is neuroblastoma and medulloblastoma. It's a cancer that occurs outside the brain in the immature nerve cells. So it can be in the spine, chest, abdomen, and pelvis. Can be inherited from the parents. Usually affect children less than 5 years of age and crosses the midline. Whereas medulloblastoma is extension of the medulla, and it's not inherited. It occurs in the lower part of the brain as in cerebellar area, affects children 5 to 9 years of age. It's associated with Gorlin syndrome and Turgid syndrome, and some gene mutations are there as well. Clear, guys? Now this is a tricky question. Pregnant lady came to routine investigations, which are all up to date. She's at 41 weeks of gestation. She's currently 2.4 centimeter dilated, head 3 centimeter above spine. Cervix is very soft. So she has Bishop score of 1. What do you want to do next? Await for spontaneous onset of labor, give prostaglandin, sweeping, or amniotomy. Very good. You guys know. So whenever patient is post dates, not going into labor spontaneously, we help the patient with the induction of labor. For induction, the first line is 8-hour catheter, and her Bishop score is like 1, which is not good. So we'll do a Prostin gel, 2 milligram, 2 milligram, 1 milligram, every 6 hourly to help ripen or irritate the cervix to bring about the labor. If Prostin is not working, or if it is progressing very slowly, then we move on to next steps of the induction of labor, like sweeping or amniotomy. If the patient has a ARM-able membranes, okay? So very good. The answer is Prostin. Bishops for less than 5, we cannot give prostaglandin. I haven't read anything like that. It's usually if the patient is post states, not progressing well, you start with there's a catheter called ATARD catheter. If it's not working, you move on to Prostin. There's no particular I haven't read. If you have any if you have read about this, Dr. Priya, can you please send it to me? But I haven't read something like that. I would be really interested to know about this. So induction of labor is to start the labor process artificially. Usually patients go by labor spontaneously by 42 weeks, but some patients will require inductions. And there are some indications for patients like having GDM, or patients with preeclampsia, or patients with twins who require induction before expected date of delivery as well. Prolonged gestation, premature rupture of membrane sometimes. For example, Queensland guideline for induction of labor. Okay, Queensland. Induction. Is this the one you're talking about? This one? Okay, let me read it quickly. Indication, maternal fetal benefit, contraindication, any contraindication for vaginal birth. Communication with the woman, membrane sweep prior to IOL, 4th page. Okay. Pre-IOL assessment. Let me read these, guys. This is good for my information as well. So we know we do a ATARD catheter, either dinoprostone. Okay. Yes, this is ATARD, which is the balloon catheter. Preferred cervical ripening agent if previous C-section or uterine surgery can multipara, following dinoprostone if no minimal effect on cervical ripening and ARM not technically possible. Okay. Dinoprostone, prostate indication, unfavorable cervix. Okay. So the first one is the catheter. Nulliparous. Following balloon catheter if no minimal effects on ripening and ARM not technically possible. So there are two indications if you read about it. If the balloon catheter has minimal effect on cervical ripening and ARM is not technically possible. And the second one is that you have an unfavorable cervix. It doesn't say anywhere that you need to do a sweeping of the membranes or sweeping of the cervix, sorry. Contraindications, wait at least 6 hours. Doesn't say anything about sweeping of membrane. Let me just read it again quickly. It doesn't say anything. It says, so there are indications like even for the catheter, if your Bishop score is less than equal to 6, cervical ripening agent should be used preferably before, if the patient has previous C-section or uterine surgery or grand multipara, or there's a small for gestational age baby, or if you have given prostin and there is minimal effect on the cervical ripening, you can use the South Australian guideline, page number 2. Okay. Essay how induction. Undertake vaginal assessment for cervical assessment and membrane sweeping. Plan IOL following full discussion with the women reviewing. Okay. Bishop score more than 6. No previous C-section, uterine surgery, no balloon catheter, prostate landing. But this is not induction of labor method, membrane sweeping, if I am not mistaken. What to do next? Wait for spontaneous sweeping of membranes. Let me just read about this, guys, and I'll give you an answer, because I don't think so they're saying sweeping as a next for induction of labor. It's just like a regular vaginal or speculum examination that you do and sweep the membranes, but it doesn't cause induction of labor, if that makes sense. So let me just read about this. You guys leave this question to me. I'll give it a read. Oh, Bishop score is very easy to calculate. Whereabouts is this one? So see, what I have read is this one, amniotomy and then membrane sweep. So usually to nulliparous woman, 41 weeks to multiparous, spontaneous delivery. That's the one. Okay, this one, guys, this is how you calculate the Bishop score. Okay. All right. Look at this, guys. Dr. Mahapuri has given us a good. So basically what you guys are saying is that sweeping of membrane is a way of doing, like every time you do a vaginal examination to assess the Bishop score, you do, yes, you have to memorize the Bishop score, sorry. Every time they do a Bishop score evaluation in a female who's coming to you for IOL, you do a membrane sweep. That can also irritate the cervix to cause on the labor. But yeah, I'll read about this and let you guys know about the answer. Sorry, I need to read. I will not give you a straight answer at the moment. Okay, next one. Patient presented to emergency department with back pain after lifting her kid up. She is 37 weeks pregnant, no abnormalities. Why can't we wait until 42 weeks? Sometimes waiting until 42 weeks can cause baby to become very dry and can also increase the risk of fetal distress as well. So it's not, if at 41 plus something weeks, then we usually ask the patient to come in for induction of labor. It's not good for the baby. Paracetamol, 37 weeks pregnant, no abnormalities on physical examination. Excellent. We should just give paracetamol. NSAIDs are not given because they cause closure of the patent ductus arteriosus. So early closure of it, but that's why NSAIDs are not given. No spinal manipulation is done in pregnancy. No treatment. It's not good to keep the patient in pain, so we don't recommend it. All right. This is a tricky question. Mother presented with 25-year-old intellectually disabled daughter. She has 3 kids with severe distress during her menstruation. Mother wants to sterilize her mentally or intellectually disabled daughter. What do you want to do next as a doctor? Assess her mental status, agree with mother, send this request to mental health tribunal, or immediately do arrangements for surgery. All right. So whenever there is a matter of a intellectually disabled patient whose carer is demanding for them to be sterilized, we refer the matter to the state tribunal authority. And they will hire their own psychiatrist to evaluate everything. So we don't do anything. We don't evaluate the patient's mental status. We just refer this matter to the state authority, and they will help. They have their own team of psychiatrists who can assess the patient and make a decision about whether this patient is for sterilization or not. Okay, so for sterilization in all of Australia, doesn't matter Western Australia or not. If the patient doesn't have the capacity to make decisions about their own or their selves, then the guardians and the psychiatrist or anyone, any doctor to whom the request is being made by the carer must refer the matter to the state tribunal authority, and they will decide what to do. Okay? No, we don't need court order. We just need to refer them. There's a whole department that deals with that. We don't need a court order, I think. I've never referred a patient, so, but I don't think so that we need a court order. We just need a form. There's a 5 to 6 page form that we have to fill. And then the state will investigate the matter, and then they will make a decision about the capacity of the patient and whether the decision about the sterilization is good and physically rewarding for the mentally disabled person or not. All right. Thank you so much, guys. This is all for today. I will give the answer. I will give you the answer for that question after going through all of 3 of the resources that we have, and I'll tell you about what is the correct answer, and also discuss it with my colleagues as well. So the practicing registrars in the kind of gynecology and obstetric departments will be able to give me a better answer and to give us a better research material about that. Alrighty, thank you so much, guys. I'll see you on 16th. I hope you have a very good night, and I hope the session was helpful for you. Thank you. Take care of yourself, everyone. See you next week.